Good evening, everyone. Welcome to this installation of the Rodham Impact Speaker Series. My name is Ashanti Carter, and I serve as the Program Manager of the Rodham Institute, which is located at the GW School of Medicine and Health Sciences. I was about to say CDU because we have one of our esteemed panelists here. Oh my goodness, but this is great. Thank you for joining us as we continue our celebration of National Public Health Week. Our theme tonight is Public Health Workforce, Essential to Our Future. So I would like to thank our partners, blackdoctor.org. Hello, everyone watching from BDO. Also, Bphsn, the Black Public Health Student Network at George Washington University, and GWPHSA, the George Washington Public Health Student Association. So now I would like to turn it over to Ms. Mara Stewart, President of Bphsn.
Thank you so much, Ashanti. Hello, everyone. Again, my name is Mara Stewart. I am the president of the Black Public Health Student Network, Bphsn, here at George Washington University. As the president of this organization, we are excited for this opportunity to be involved in this discussion. Our organization exists to support and guide public health students of the Black diaspora and allies at the George Washington Milken Institute School of Public Health in academia, professional, service, and social endeavors to encourage cooperation, foster a highly involved community, and to advocate for sound public health for the Black population at large. Representation matters in the public health workforce, from the entry-level positions to the CEO and every position in between. I would also like to give the remarks from PHSA. Sadly, Connor Honchell could not make it tonight and has asked me to share his remarks. Hi, everyone. Thank you for joining us for this important event during National Public Health Week. Connor is the president of the Public Health Student Association. He appreciates this opportunity for the public health students like me to learn about the impacts of racism on public health. We are aware that public health is impacted by the system we live in, such as housing, healthcare, and criminal justice. As racism and white supremacy are built into our systems, being aware of them and their impacts is a crucial step towards improving public health. As public health leaders of tomorrow, this is an important lesson for our students to learn. Thank you again for being here. And I'd like to turn it to Dr. Gigi. Thank you.
Okay, well, thank you. And this is terrific. We've got really just A++ panel here this evening. I'm Dr. Gigi Ilbayumi, Professor of Medicine, Founding Director of the Rodham Institute here at GW School of Medicine and Health Sciences, where we're actually dedicated to improving health equity right here in Washington, D.C. I would invite you to go to our website, sign up for our newsletter, learn more about what we do. Our 3 areas of focus actually include workforce. This is a high priority. And of course, we've got over 160 partners, so we are just delighted to be here. So, the topic of tonight's conversation is really going to be focused on the public health workforce. And before we get started, I just wanted to make a few comments. I'm a clinician. Matter of fact, I just finished clinic. And we're also part of the Maryland Regional Direct Services Consortium collaboration. And during this time of COVID, 1 in 3 people, mostly women, African-American women, who were in the direct services workspace actually stopped working. Why was that? They stopped working because they did not have adequate PPE protection for COVID. They stopped working because of the competing priorities that they had in their home to care for their elderly parents, didn't want to get themselves sick and bring home the illnesses, having to oversee multiple kids in school. That is, if they had adequate digital connections, network connections, and adequate computers. So the impact on that is that really the inequities have actually increased during COVID. COVID is just the latest, it's almost like the punctuation mark. So with that as a backdrop, I'd like, we'll start off with you, Dr. Carlisle. If you could kindly introduce yourself and just maybe tell us, first of all, what does public health workforce, what is that? How do we even define that? And welcome. Thank you for joining us.
Thank you very much, Dr. El-Bayoumi, for that introduction. I am Dr. David Carlyle. I'm the president of Charles R. Drew University here in Los Angeles. We're a health professions school focusing on preparing health professionals to serve under-resourced communities by taking individuals from those communities and bring them into the health professions. So yes, I'm also a physician in internal medicine. And before coming to CDU some 10 years ago, I was Director of the Office of Statewide Health Planning and Development for the state of California, which is the unit that is largely responsible for health professions oversight for the state of California. Here in Los Angeles, we certainly saw the public health impact of COVID-19. The community around us is one of the biggest under-resourced, underserved areas in the entire United States by population. And the impact of COVID didn't get any more stark than it was in South Los Angeles. But interestingly, that wasn't always felt to be the case. And early on in the pandemic, it was quite clear that if you were getting COVID, you were somebody from the more affluent communities on the West Side, somebody who was doing international travel, somebody who had access to testing. And that basically got us off to a false start. But people in public health were basically saying the actual issue is if you don't test it, you don't see it. Or to quote a famous publication, if you don't take a temperature, you don't find a fever. And the problem in Los Angeles is we weren't looking for COVID in under-resourced communities when we should have been. Until the public health community rallied and said, it is here too. In fact, it's even worse than it is in our affluent communities because with so many people on the front lines doing essential jobs who could not take time off from work, who couldn't order sushi to be delivered at their houses from a 5-star restaurant. And it became a public health crisis in Los Angeles. Fortunately, we have very effective LA County public health leadership, Dr. Barbara Ferrer. LA County supervisors were very unified in their approach to COVID-19, and the county responded. And we responded by bringing, for example, testing into South Los Angeles. On our own campus here at CDU, we were testing 80,000 people during the first year. So our public health community was able to identify the gaps in the perception of the pandemic and respond to those gaps. Despite that, the challenges remain that we're all familiar with death rates 2, 3, 4 times higher in under-resourced populations of color. And that remains, I think, a defining characteristic of the COVID-19 pandemic.
So I forgot to say congratulations, which I know that Dr. Chen will echo again, for having been a Macy Foundation recipient for the Charles Drew University's work on social mission. Yesterday, actually, we had the executive director of the Beyond Flexner report join us, and we actually talked about the accountability that the late Dr. Fitzhugh Mullan brought with his work in the first report, I guess in 2011, to really score institutions based on their social mission and how close we are to actually serving the people that are in our community. So congratulations and thank you.
Thank you for that. Thank you.
Thank you. Dr. Candice Chen, would you be kind enough to introduce yourself? And COVID has been the backdrop. How do you see sort of the public health workforce, being either what's needed, what are the shortfalls in that context? Because I think COVID is just the natural context in which we can talk about this.
Yeah, absolutely. So I'm Candice Chen. I'm an associate professor of health policy and management at George Washington University in the Milken Institute School of Public Health, but I like to call home the Mullan Institute for Health Workforce Equity. And what we focus on is the role of the health workforce in advancing or sometimes not advancing health equity. And, I think that the question is, actually the first question that you asked was such a good question, which I think was, what is the public health workforce? And I'll actually defer and let Dr. Vichare answer that, because I know that she's been thinking about that issue a lot. But I think that, it's a little bit like you said earlier, COVID-19 has put an exclamation mark on so many things, including the public health workforce and our just historical underinvestment in the public health workforce and in public health infrastructure. It is definitely one of those things where when public health is working well, and I think it worked about as well as it could given the infrastructure that we had and given the global pandemic. But when it's working really well, we don't see it. And when we don't see things, sometimes we stop paying attention and funding those things. And so I think COVID-19 has just, taken the top off of this box and shown us that we need to rethink our public health system. We need to reinvest in our public health workforce. And we always look for those lights in darkness. And I think that the one light is that COVID-19 is just increasing people's interest in being a part of the public health workforce. So, the question is where do we go from here? I think I'll pass it to Dr. Vichare, because I think that question of what is the public health workforce is actually a really good question.
Okay, well, thank you, Dr. Chen. Without further ado, then Dr. Vichare, please introduce yourself and please help answer this question. What is public health workforce?
Thank you. That is a great question and a really difficult one. So I'll do the easier part first, which is introducing myself. I am Anushree Vichare, and I'm an assistant professor in the Department of Health Policy and Management. Everything else follows exactly what Dr. Chen said in the Milken Institute School of Public Health. And again, I also call the Mullan Institute my home. A lot of my work is, I'm a clinician, an epidemiologist, and a health services researcher. I think that gives some hint of what the public health workforce actually entails. So I think the challenge in the public health workforce studies or research has just been being not able to define clearly who the public health workforce is. If you look at it from sort of a broad buckets, you could divide it up as governmental public health workforce. Typically that works for state, local health departments, tribal health agencies, or you could think about it from a non-governmental public health workforce. I think COVID-19 has clearly suggested that the delineation between clinical care and public health care is quite blurred, right? Especially given the attention on the social needs that individuals have, which clearly cannot be addressed unless and until you are in the community. And so clinicians, right, are playing an increasing role in some of the public health activities. The one example that comes to mind are school nurses. And Candice and I, that has been our interest at Mullan Institute as well. And how would you then classify what bucket, right, would you put a school nurse in, a clinician or a public health workforce? So the challenge really has been is that we don't have standard definition for who the public health workforce entails. And that has led to this problem of enumeration and in being able to count the bodies to estimate and say, here is the supply, here is what the demand is, and here is what the expected shortage is. So a lot of the work on the public health workforce, particularly in terms of shortages, comes from the enumeration of the governmental public health workforce. And I think that's because they are easier in terms of the job titles, although the responsibilities may vary across states and local health departments. But a lot of the work around the staffing up of public health workforce is primarily drawn from the governmental public health workforce. And to that point on the impact of COVID-19, particularly on the public health workforce, In 2008, so the shortages of the public health workforce isn't something that we're facing today. This has been an historical challenge. In 2008, ASPPH had warned that by 2020, we are probably going to face a shortfall of more than 250,000 public health workers. Public health jobs that were lost during the 2008 recession were never replaced. And as Dr. Chen mentioned, the public health funding has been strained for decades now. And we are finally, I guess, gaining traction and attention. That has been one of the silver lining of COVID, is in understanding that we do need investments in the public health workforce. And so it's not just about the number of bodies, right, that are required for functioning and providing public health. It is also the health of the public health workforce. The Beaumont Foundation has periodically done the public health workforce interest and needs survey, or the PHWIN survey. And their latest reports that were published in March 2022 have suggested that nearly 1 in 3 public health employees say that they are considering leaving their organization or leaving public health. They are underpaid, overworked, stressed, burnt out. A lot of them are experiencing PTSD just from the experience of COVID and dealing with all of the challenges of COVID. And so the shortages are going to worsen because we're going to have significant employee turnover. And many public health workers have also reported bullying, threats, harassment, right? So there is also this aspect of just the moral injury of the public health workers that we also need to consider. So it's not just about ensuring that we have a public health workforce, but we also want to make sure we have a healthy public health workforce.
Before I sort of turn things over to my esteemed co-moderators, both of them, I have a question for you, Dr. Carlyle, because having received the recognition as being a leader in sort of social mission, please educate us and the audience of what makes Charles Drew University different. What is it, let's say, compared to, let's just put it out there, GW? Why is it that you are doing better in terms of social mission than we are? I'll just say it like that. Let's have that conversation.
I will certainly accept your perspective. As somebody whose home on the East Coast is in the DC metro area, I've always looked up to and admired GW and have had colleagues there for many years. So I can't make a comparative statement, but what I will say is that social mission is in the DNA of Charles R. Drew University of Medicine and Science. We were founded in 1966 in direct response to the Watts Uprising of 1965. Our mission statement uses words like social justice and health equity, diversity. And that's why students come to CDU. I'll often stop a student and say, why did you decide to come here instead of going to, say, USC or Stanford? And they'll say, because my mission, my personal mission as an aspiring health professional aligns perfectly with the mission of this institution, and I can't get that anywhere else. Our vision that we're trying to achieve through our mission is excellent health and wellness for all in a world without health disparities. So this is exactly why CDU exists: social justice, service, equity. We were put here in response to the compelling needs that were identified after the Watts Uprising of 1965. We consider ourselves to be a community-founded institution, and we use the phrase a private university with a public mission. That's been CDU, and I think we've been true to that purpose since our founding 55 years ago.
Well, I have to tell you, one of my friends and one of my mentors, Mrs. Cora Berry, is from Watts. For those of you that don't know that, the late Mayor for Life, Marion Berry's widow, is actually from Watts. And I remember, because of my age, my mother taught us about the Watts IQ test. And for those people who don't know what that is, people do better on the IQ test, the conventional one, the closer they are to Boston. because the people that are preparing the test are from the Boston area. So of course, their kids are going to do better. But in the 60s, I think it was some anthropologists and other activists basically said, well, let's look at the information and the knowledge and the experience of people from Watts. How would everybody else score on the Watts IQ test? So Watts has a very special meaning in informing my education. I'm going to go ahead and toss it to my co-moderators to allow them a chance to ask the important questions.
No, but that was great. Thank you, Dr. Gigi. And thank you, Dr. Carlyle, for discussing Charles R. Drew University of Medicine and Science. For those of you who are watching, I am an alumnus of Charles R. Drew University of Medicine and Science. I earned my master's in public health from CDU. And what Dr. Carlyle stated is true. We eat, sleep, and breathe the mission. So, I'm so thankful for my time being at CDU. So yesterday, panelists, we talked about the shortage of physicians, and we also talked about the Flexner report and how it impacted our health. Can you tell us, why is it important that we have a diverse workforce? How does that impact the care of our patients? And anyone can start us off.
Well, I'll go first, and I'll do it with a story. And I've gotten into the habit of telling more and more stories, so I won't stop here. So here I am. I'm a primary care doctor at a clinic, and I'll say UCLA. That's where I was on faculty for. I'm still a faculty member since 1992, and I'm a health services researcher, getting tenure, doing my number crunching thing, but I'm still seeing patients. And one of my patients was a department chair, one of the more powerful faculty members that you'd ever find at UCLA. And so we were on a first name basis, and he said to me one day, Dave, do you ever wonder why I picked you to be my doctor? And this is a guy with every advantage. And I said, well, yes, I'm here as a researcher. If you show up in the emergency room, I'm not going to come down and see you. If you need an urgent care visit in the clinic, I'm going to ask one of my colleagues to see you. If you get admitted to the hospital, I'm not going to be your attending. I'm going to come by and shake your hand and ask you how you're doing. But you're not going to see a whole lot of me because I'm on the research faculty and I'm trying to get tenure. And he says, I totally understand that, because that's what I do too. But then he said, the reason I picked you to be my doctor is because if I'm lying on a gurney in the emergency room, or I'm hooked up to a ventilator on pressors in the ICU, and somebody's got to make some decisions about me, I want you to be there to make those decisions, because I'm African-American and you're African-American. And I can't get that here except by having you as my doctor. And again, this is somebody with every advantage, like a Serena Williams, who still spoke to the issue of disparities and the importance of concordance between providers and patients. This is a big deal because it speaks to trust and confidence in the healthcare system. It speaks to why communities of color were avoiding getting vaccinated against COVID-19. This is a continuum, and it kind of comes full circle as presented by this professor and department chair at UCLA.
Wow, that was powerful. Powerful, Dr. Carlyle. Any other panelists? Dr. Chen, Dr. Vichare?
Just echoing what has been said, a lot of my work looks at the role of concordance, which is built on the idea of shared identities, which builds the trust. It helps to establish, communication is the key, right? And so being able to have that trustworthy open channel of communicating with your providers is really important. From a public health perspective, it's really key that the public health workforce is representative of the communities they serve. Again, trust is the key here. So I agree. I think it's the engaging word here is really establishing the trust in the messaging, as particularly as we've had quite mixed signals about science, and our beliefs in science have been shaken over time. And so the communities really need to be able to hear messages, health communication from a workforce that they can relate to, that they feel like they have shared experiences, lived experiences with, and that they can trust.
I don't think that any of us could say it better than Dr. Carlyle just did, but I do want to pull out something that he said, and share that I've been reading a lot of Catherine Phillips' work. And if you don't know Catherine Phillips, she was a professor at the Columbia School of Business who studied the value of diversity. She studied small teams, and unfortunately, I think that she passed away about a year ago. And I never knew her. I just looked her up once I started reading her work. She passed away of breast cancer, but she studied what diversity did in small teams. So not using big data or anything like that. She was a sociologist, I believe, by background. And when she studied small teams and brought more diverse teams together, what she found is that they acted differently, that they didn't come in with assumptions, that they came in kind of shedding their assumptions, and they spoke differently to each other. They tried to draw out different different information from each other, and the answers that they came to were often better answers. They were more innovative, they were more inclusive, right? And this thing of, in public health, in healthcare, on these issues of trust, we have just the most complex problems you have out there. And if you only bring people to the table who will look just like each other, we're not going to get the answers. And where did we see that other than in COVID, right? Not to bring it back to COVID. So there is just value in diversity, in truly valuing diverse experiences and diverse perspectives. And we cannot fix the problems that we have without bringing everybody to the table, and soliciting and valuing their viewpoints. And then the one other thing that I would add is I think when it comes to diversity, we'll say anti-discrimination in the public health workforce, in the health workforce, I think that there is value for healthcare and for our patients and for communities, but we have to deal with equity inside our walls too. Like what you look at all of the higher income, higher education professions compared to the lower income professions, you see a flip in both gender and in race ethnicity, right? And we have a real problem with equity, justice inside our own walls. So yes, the value to our communities, to our patients, but also just we have to fix ourselves if we're going to, turn out, I think, as well.
So if I can just also respond as well to add something before Mara, you take over. Charles Drew University, one of the former presidents is of course Dr. Reed Tuckson, and he helped to, sorry, my cat is always jumping in, was one of the co-founders of the Black Coalition Against COVID, of which the Rodham Institute is a part of. I'm very proud of the work that we've been doing that has really been able to bring all the significant, people, community, the healthcare folks, the faith-based, just and also the nurses and community health workers, because it was so key that we dispelled some of the founded myths that were there. We partnered with the Tuskegee, the descendants of the Tuskegee, people that participated or were used in the Tuskegee experiment, and hearing from them about why they believe in COVID vaccinations. It's a lot of work, but it can only be done by people who have an appreciation. It's not necessarily melanin content, but at least the appreciation of why it is that somebody rejects getting the COVID vaccine. Why is that based on fear? I say that, the European settlers were the first people to introduce biological warfare, as far as I know, in the world. They were the ones that brought in the smallpox infected blankets and handed them to the Native Americans and wiped out, they wiped out millions, not just through that. So the strongly held beliefs, which are conspiratorial, well, there are conspiracies where they actually are correct. So I would just want to point to the great work that the Black Coalition Against COVID has done. And I really urge everybody to look up the website, because I think we learned a lot, and we'd like to share what we've learned with others about how to help get people to change their mind by looking at the diversity. That was one of the big things, to see that Dr. Of course, I'm going to forget Kizzy, who was one of the people that worked on the Moderna vaccine, was involved. Wow, that changed some minds about getting the vaccine. All right, I'm going to stop here and toss it to you, Mara. Otherwise, I'll talk all day and all night. I'm going to put myself on.
Thank you, Dr. Gigi. You always have a very fantastic point of view, and I always love to hear it. So for our panelists, I'm about to graduate with my MPH this May. So I am new into the workforce. So do y'all have, as I'm looking at these different jobs, and I know a lot of different students are currently going through this similar struggle, that when we are looking at the diversity of these jobs that we are trying to go into, it might be diverse on the lower end, but then as we look at higher positions or who is interviewing us for these jobs, we notice that the diversity is decreasing as you get higher and higher up into the workplace. So my question for y'all is, what advice would y'all give for the new upcoming workforce of these new students? And there's a lot of diversity here, but when we start to get discouraged, when we look at these organizations, and we're kind of sitting and scratching our heads of, is it we want to continue to be a part of our identity, having that strong racial identity, but also in a lot of these work environments, you often feel like you have to pick one or the other. You can't be the loud Black girl, you have to be quieter, or you can't be this, or you can't be that. And you have to struggle of, what aspects of my identity am I able to show in the workplace and still get these jobs? And that's for any of the panelists who would
anybody jump in. Yeah. That was loaded. That was loaded, Ms. Mara.
Nobody wants to go on unmute. But the thing is I think that you started off with a really good almost answer to your own question is as you look up into the organization, what do you see? And that says a lot about an organization. Now, does that, if I could take a step forward, as people are looking at their MPH programs, as people are looking at their medical schools or other universities, there was something that Dr. Carlyle and then Ashanti kind of echoed of the mission of Charles Drew is social mission, and is to cultivate and to support students who have historically been marginalized. And oftentimes when I advise students who are looking at medical school or looking at master's programs or looking at others, I like to ask them, what kind of, if it's medical school, what kind of doctor do you want to be? And when you think about what kind of doctor do you want to be and who do you want to be, then you pick on those characteristics, right? And oftentimes it's not going to be the GWs of the world, but it's going to be the Charles Drews of the world that will give you the experience and support you in the way that you deserve, right? And when you're early in your career, I don't think it's wrong to look at organizations in that way. I also have to turn it, and particularly right now, we're watching some people who are inside of some organizations that haven't historically been leaders, we'll say, in the space of health equity and justice, and are working and doing the very hard work of working from the inside to try to change those organizations. And I'll just share, we just came out of the Beyond Flexner conference, and we had Dr. Aletha Maybank, who is running the Center for Health Equity at the American Medical Association, and really spearheaded their strategic plan to advance racial equity, recognizing the role that the American Medical Association has had in promulgating, I think, racism, including supporting the Flexner Report from 1910. And I have to say, she gave one of the most powerful deliveries that also just shared how hard it is for her as she is moving this work forward. So I also just value so much the people who are inside of organizations who continue to just every day push and keep moving the organization forward. But I always say that with a lot of caution, because I don't believe it is any individual's responsibility to do that. And I think that would be my other kind of maybe bit of advice is when you're trying to change organizations, and when you're trying to change organizations in the most difficult space possible, I think one of the most important things is to find your collaborators, your peers, your partners in this. That mostly we are not alone. There are others who care. And for students, it might be faculty, it might be leaders, it might be other students. In a new job, it might be your coworkers, but it might be some of your supervisors and your leaders as well. And we find those people, and then we organize. And together, we can change. We can make change. But you don't have to be alone. Yeah,
that was very well said. Thank you. I think it's important to have, I think, these conversations, because it is not the world of public health is a very interesting world, and we've already seen it is diverse in certain aspects, but then in other departments it's not, and that is the true reality. And there is a very big fear, I know, for a lot of the people who are graduating, of they do not want to be another token. And I think that is another part of this conversation of how do you go into these spaces, you don't want to be just the token POC BIPOC person, but you also do want to create this change that you are speaking of that is so important to start changing what we see in these organizations. So thank you.
If I could just add to, it is okay to focus on basically making a living. That nobody's going to judge you, especially when you're in these very difficult positions that you want to establish yourself. Because I think there can be a lot of pressure, self-imposed and external, when you do have views and really the passion for social change, especially if you're one of just a few people, to feel like you've got to do it all. It is okay to focus on yourself, your work. Remember, this is a marathon. This is not a sprint. The work will always be there. So maybe somebody my age can speak out more because I'm established, but my responsibility then is to support you and younger people who have other, competing priorities that may get in the way. So I think we have to be also mindful of not judging others or judging ourselves for what we can do, because let me tell you, Mara, when you are in a space and you're working at X organization and the person who's the custodian is there and is not seen, and you have a conversation with her and you ask about her family and how she's doing, that is working towards equity, because turning somebody from invisible to being seen. So I think we sometimes focus on big ticket items, but remember, just by who you are and how you're conducting yourself, you are making a difference.
I'll add, Mara, in agreement with all the other comments as well. One thing is for sure, time is on your side. And as the United States changes, we need to look no further than California right around me. We are no demographic group constitutes a majority of the state. The largest population is the Latinx population in California. It's redefined the political reality and the political agenda of California, and it's refocused priorities. But you don't want to wait 2 and 3 decades. Or in the case, to quote the researcher David Hayes Bautista, we can't wait for the secular trend of Latino diversity to catch up with the state of California, because it's going to take 500 years before we achieve medical profession representation equal to population representation if we just wait for secular trends to occur. We're making progress, but we don't have 500 years. I would say one thing, I would take advantage of levers of power. And to do that, you have to have enough people to push down on the lever. So you can't do it alone, I agree. But you also want to place that lever where it's most effective. And the most effective or responsive parts of an organization are actually at the top of the organization, whether it's a university board of directors, trustees, regents, corporate boards. You can't change a organization's culture incrementally, or it's going to take forever and it's going to take a lot of energy. I would say go directly to the point of power and match power with power. And I think you'd find probably more responsiveness at that point, and certainly a greater ability to implement and accomplish change within an organization. So if I was thinking collectively about how I might want to change organization X, Y, and Z, I would get a group together and I'd have a discussion. Maybe I'd even be, kind of a pain in the butt with the organizational leadership and make them respond to me.
Awesome.
It's a very hard act to follow. But may I say, piggybacking on what you were saying about power, students have the power to make the choice, to think about what is important for your work ethic and who you want to be. And the greatness of power is, there is this increased push towards accountability, right? We got to hold institutions and organizations accountable. We've been letting people off the hook for a very, very long time in our country. And what transparency and metrics do, something like social mission, is being able to recognize institutions that are doing extremely well on their social mission. I shout out to Candice and her work with Phsn on the social mission, and the US World Rankings this year published the social mission rankings of US medical schools. it's a huge step forward, right? It really says that we are watching you. We are watching what you're doing. These are the things that matter to us. These are the choices that we are going to make as students. So you have a lot more power than you think. And it's the pipeline of the students just excites me so much, even at GW and other universities. But you have a lot of power. Mara, go for it.
Thank you.
We've said the exact same thing at yesterday's panel,
Yeah.
that students underestimate their power, and really you would be surprised what is said at the higher levels about student opinions. I'd like to ask a question that's going to shift things a little bit, and that is about community health workers, medical assistants. We're part of the DC Healthy Housing Collaborative, and one of the very innovative things that is being looked at is to actually train community health workers around environmental health. Because here in DC, we have a program which will allow the lead pipes to be replaced. And yet people who live in areas where that's a real issue don't know about these. So the Healthy Housing Collaborative is actually involved in training people to do so. So can we talk a little bit about how people who live and come from the community probably can make the biggest impact, and what you see in that particular workforce and its future?
We have this program at CDU. It's our community faculty program. And one defining characteristic, we were talking about the Watts IQ test, is what we call the PhD of the streets. And this is part of what it means to be a community-founded, community-oriented institution, because there is so much wisdom out there. And we simply are a vehicle to allow that wisdom to be harnessed and utilized appropriately. The ability of community health workers to carry a message into the community effectively, and not into, but embrace a message for a community is powerful. And so if you want to work with communities, then basically you have to work with communities. And community health workers, or promotores, for example, one group, that's a powerful agent for change. And I would say that if we are focused on public health, those are public health deputies out there waiting to be deputized, because they know how to carry the message in an effective way, and they're motivated to do so. And environmental justice is one great example, because we've seen how water issues plague under-resourced communities, especially populations of color. And that's a compelling issue, and solutions are there. And I would say community health workers are an effective change agent in that context.
Anyone else want to jump in? But I was a community health outreach worker back in the day. I was not paid a livable wage. So what can we do to change that? Dr. Vichare?
We've been thinking about the community health workers and the role they play, particularly in behavioral health. As the behavioral health needs of our nation have gone up significantly, COVID, and clearly there are workforce shortages. And so, as we said, if we keep waiting on developing a pipeline that is going to eventually meet our needs, we're going to be too late. So then where do we start, right? We start recruiting from the communities, and it's so critical. There are several models for particularly that pay for education of interested applicants. And I think that's the key, right? It's one thing to bring a workforce, right? Bring individuals into the workforce. So there's recruitment, and then there's the other issue of retention. And I think we don't pay a whole lot of attention to retention. So, using staff satisfaction measures, is really important, not just as some checkbox, right, that is ticked off, but really for quality improvement. There are several evidence-based strategies that have successfully shown that if you provide opportunities for professional development and growth, it's important for retention, right? Job satisfaction is important. Salaries, of course, is important. Benefits, right? You know, something as simple as providing transportation, right, which can act as a significant barrier for community health workers. So I think that what we need to understand, and I started with this before, and I probably want to end with that too, is really addressing the health and the needs of our workforce. Right? I think we often forget the health of our health workforce, and I think that is really the key in ensuring that we are able to retain a healthy workforce.
Actually, here in DC, we're the Rodham Institute is part of a group that is pushing for 2022, meaning a minimum wage of $22. And I would invite people to again visit the Maryland the Maryland Regional Direct Services Collaborative, because we actually commissioned a study by a PHI to look at the workforce. It turns out that in DC and Maryland, but particularly in DC, 1 in 5 people that are working in the direct service space are actually on government subsidies, right? And as I said earlier in my earlier remarks about the COVID pandemic and what that has done, I think, you know, what we're trying to do is to really look at it from multiple layers, from middle and high school, but also, you know, in Ward 8, only 42% of people have graduated from high school. So to give opportunities. One thing that I learned from the work that we've done with the other organization is that it is important that we don't use, I offended somebody unintentionally. It was somebody who was a direct service person who was talking about her job and so forth. And she said, don't assume that I want to go on a pathway. I'm very happy within this pathway. So to talk about what opportunities there are for her to teach others, to have leadership, and to have increase in pay. So we learned a lot. I would invite you to go to that website, because we have the different issues, but we also have solutions that we have on that website, so you can look at that. There are so many innovative models out there. Grand Rapids, a lot in the Midwest. I'm partial to the Midwest myself. That's where I'm from, Michigan. But there's a lot of work, but the bottom line is still money. It's poverty. It's pushing for equitable pay, as we all know.
Yeah. So looking at the future of our public health workforce, and it is essential, but as you know, education, there's so much work that still needs to be done. So what can universities like CDU, and with the work that you're doing, Dr. Chen and Dr. Vichare, what can universities and colleges do to recruit and retain more students of color who are interested in going into a health profession?
Well, that's that's a kind of a question up our alley. We are the #2 most diverse not-for-profit 4-year university in the United States at CDU. But that's in both student diversity and faculty diversity. But we're of course in a very, very fortunate position, because we were created with that diversity goal in mind, and we continue to deliver, and it's self-perpetuating, of course. But I think the other role that we can play is we can provide examples to other institutions to prioritize the same things. And if you really want to focus on improving population health, you need to focus on where the return on investment is greatest. And those are under-resourced communities. Under-resourced communities in population size are predominantly communities of color. Not entirely, of course, but predominantly. And that means that if you want to be responsive to the needs of those communities, you have to prioritize the values and the priorities of those communities. And that means diversity. If you really want to get it done, you have to practice what you preach and walk your talk. And that means diversity. And I think that more and more organizations are coming around to and seeing how important that is. If you want to market your health plan to an urban population, diversity, et cetera, I could keep going. But that's the important message. And I think we've been in a position at CDU where we've been able to practice this as our mantra for decades.
Thank you. Dr. Chen?
Yeah, I think I hesitated because mostly my thought was, oh my gosh, so much. Universities could do so much and need to do so much. But actually, to follow Dr. Carlyle, I think that we've been thinking a lot about that idea of centering education in communities, and how do our colleges and universities be good partners? It's kind of the anti-helicopter model, right? And how do we turn our colleges and universities to really think about how to partner and again, partner and come to the table as equals, valuing the strengths and the viewpoints and the manpower that our communities bring to us, and then partner to think about how do we build pathways and invest in pathways, not just when we get grants from foundations or from the state or from the federal government, but how do we take our core funds and resources and invest in the community and invest in the pathways and partner for long-term partnerships to bring the community into, to achieve diversity in a collaborative way. And that is into elementary schools and community organizations and up through high school, community colleges, and partnering with those community colleges, which are four-year institutions, and where many of our higher education medical schools are located, have done a very not good job of partnering with those community colleges, of bringing and supporting people all the way through, and then of changing our own, getting people in the door isn't enough. We have to think about what happens to people. We know that based on our race, ethnicity, based on gender, based on our sexual orientation, that our students are experiencing higher levels of discrimination, bias, microaggressions, that they don't see the same educational opportunities. Those are all things that we have to, it's just so much. It's just so much. But students are demanding it. Faculty are demanding it. Communities are demanding it. Now is the time to keep pushing and to not let off.
Wow, we need to have a part 2 because I think we're almost out of time, and we could talk about this, and we need to talk about this more. I'm so glad that this has been the Public Health Week, so that we've been able to touch on these ideas. And perhaps what we should do, Dr. Carlyle, is to invite you to give a special seminar, special summit for us at GW to learn from, because I think, there are a lot of people that are interested in making change, but what does that really look like? How do you really operate, that word, how does that do? So I'd like to, before I give the final word to my two co-moderators, I just want to say thank you on behalf of the Rodham Institute for a rich and robust education and conversation. Dr. Carter?
Oh no, I'm going to pass it to Ms. Stewart, and then I'll end it. Go ahead, Mara.
Okay. I just wanted to thank all of y'all for joining this panel today. Thank you again for letting me even join this wonderful team. I look up to all of y'all. I hope when I get into my career, I can be just like half as great as y'all. Like y'all are really changing the world. And I just like am so appreciative of being part of this discussion. Thank you again. Another shout out to BPHSN and PHSA from GW. Thank you.
Yes, thank you so much to our esteemed panelists for a wonderful conversation. Thank you, Dr. Gigi. Thank you, Ms. Mara Stewart. Thank you, Dr. Carlisle. You are amazing. Thank you, Dr. Chen and Dr. Vichare. And of course, to BDO, GW, PHSA, and BPHSN. Thank you so much. It seems that with public health, with the future of our workforce, we must go into the community. That's the future. Go into the community, make sure that we have pipeline programs that are built so that we can take care of each other. That's the only way we can achieve health equity, and just building long-lasting, robust partnerships, right? Iron sharpens iron. So our community, that's where the iron is. It's there. So thank you again for joining us, and do take care of yourself. Bye, panelists, stay on the line.